Hi there, my name is Emily, and I'm going to be doing my project on the gender pain gap. To start, we can define the gender pain gap as a form of discrimination within the healthcare system where an unconscious medical bias contributes to women's pain being written off as a normal part of womanhood. It can also be defined as just the documented difference that's found in the perception and assessment and therefore treatment of pain between men and women. For example, research indicates that women are at a significantly greater risk for most common pain conditions. Over 80% of all autoimmune diseases occur within women, so think things like fibromyalgia, chronic back pain, migraines, so on and so forth. Despite this, our understanding of the pain difference between men and women remains preliminary. Some of the ways that we see this are women are significantly underrepresented in medical research and clinical trials. This is something that we read a lot about in the first module of this course. One of the ways that we can also see that is that just in laboratories, cells in animals that are used for research are primarily male, and clinical trials as a whole are performed almost exclusively on men. This means that overall medical research is performed and perfected within men, and then those findings are just applied to women, assuming that women will respond the same. Additionally, women are more likely to have their pain be dismissed as something that is emotional, or that their pain is something that they're exaggerating, or that it's related to stress versus an actual physical medical condition. Women overall are more likely to be given sedatives when expressing pain versus men who are more likely to be given actual pain treatment. Women as a whole are just less likely to receive adequate pain treatment. For example, in a 1994 study of 1,308 outpatients with cancer, of the 42% that were documented as not having adequately treated for their pain, women were significantly more likely than men to be undertreated with an odds ratio of about 1 to 5, which is quite staggering. Also, women are more likely to suffer from a delayed diagnosis than men. One way that we can illustrate this is 1 in 10 British women, for example, and people with female reproductive organs, 1 in 10 suffer from endometriosis. Despite this quite high amount of people suffering, it still takes an average of 8 years for them to be able to receive an actual diagnosis. Now, why is this? Well, when we think about it, historically, women's ailments have been dismissed as emotional issues as a whole, as opposed to legitimate physical problems. We also have seen lots of women's ailments being written off as hysteria. Hysteria, which was something that is documented as being first used in 4th century BCE, so quite a while back. It was a widely accepted medical diagnosis up until the 80s when it was formally removed from the DSM. This worked to overall pathologize women's health issues. Jumping forward quite a bit, in 1977, in response to the thalidomide tragedy, the FDA released stricter guidelines for clinical trials, which excluded women from participating in early phase research, with the one exception of life-threatening conditions, which still represent a small fraction of all the clinical trials taking place. So, as a whole, women are not included in research. And this was a guideline that was not reversed until 1993. Formally, the gender pain gap was first formulated in 2001 by a study from the University of Maryland, which was called The Girl Who Cried Pain: A Bias Against Women in the Treatment of Pain. This conducted research that found women are overall more likely than men to be undertreated or inappropriately diagnosed and treated for their pain. It was a landmark study for a reason because it synthesized decades and decades of much smaller studies that had been conducted beforehand, and it presented a formal description for the gender disparity that we see in the perception of pain and the pain treatment. And it gave us our modern framing for the gender pain gap today. However, a Harvard Medical School still finds that as of 2019, women are substantially underrepresented in clinical trials for leading diseases. So while progress has been made, we still have not overcome that barrier. We are still significantly underrepresented. Some more consequences that we can see of this underrepresentation are men overall get viewed as more homogenous. They have a 24-hour hormone cycle, which is viewed as less hormone fluctuations, therefore less variability within testing. So they are seen as just overall easier and cheaper to research and study. Therefore, most medical research is performed on men, but the results just get copy pasted and applied to women, assuming that women are exactly the same as men, with the only differences being our reproductive organs, which then it further pushes women's health to become synonymous with reproduction, leading to something that's been coined as bikini medicine, where women's health and women's medicine is viewed as only the things that are covered by a bikini, meaning breast health and reproductive health, because those are the places where we are visibly differ from men. This can be seen in things like heart disease, for example, which is a number one killer for both men and women. However, women are significantly more likely to die within our first year following a heart attack than men are. And part of the reason for this is that men's symptoms are viewed as typical, while the symptoms that are presented by women are perceived as atypical. So men report symptoms, heart attack symptoms, as crushing chest pain, whereas women report just not being able to get a full breath in, or feeling more tired than normal, or something's just feeling off as a whole. And because of this, and because these symptoms are seen as atypical and men's are seen as typical, when women go into the hospital reporting these symptoms, they are less likely to be admitted for symptoms of a heart attack. They're turned away more often than men are. This is referred or has been coined as the Yentl syndrome, which kind of refers to the pattern of women being less likely than men to be diagnosed and treated for certain conditions, particularly heart disease. And it kind of refers to the way that women have to almost prove that their pain is as bad as a man's in order to receive treatment. And then this bias extends further. We also see an overwhelming male bias within neuroscience, with a 5.5 to 1 ratio for experiments studying males to females, so men being significantly more included in research than women. And there's a similar bias that we see in pharmacology, which is exceptionally dangerous because this is medicine. And one of the consequences of this can be seen within Ambien. Ambien was a prescription that was primarily written for women because women suffer from sleep disorders more often than men do. Now, the prescription Ambien had been on the market for well over 20 years before the FDA released a statement saying they recommend cutting the dose in half for women. This was because it had been realized that women metabolize Ambien at a much slower rate than men do. Slow enough to lead to the suggestion of cutting their dosage in half, halving the dose completely. And this is because women were waking up with more of the active drug in their system. That means waking up with increased drowsiness and then doing things like driving to work, which is dangerous because then they're operating automobiles while impaired. They're driving impaired, which is incredibly dangerous. And this wasn't something that was discovered until 20 years after it had been put on the market. And this is due to women not being included in research. But it is not all doom and gloom. There has been a lot of progress and promise. There is overall more increased awareness and more research on this phenomenon. And specifically, there's been greater increase in research on the neuroimmune system. Pain and the immune system are tightly linked. Like, for example, inflammation is an extreme source of pain. The nervous system and our immune system communicate extensively, and they direct each other's activities. This can be seen in some of the research that's come forward in more recent years. For example, human sex-related differences have been demonstrated to show lowered pain thresholds, enhanced pain facilitation, and decreased pain inhibition, and likely differences in immune response to even tissue injury between men and women. So research is showing that there is a significant difference between how pain is, the process of pain in men and women. And a number of funding agencies now emphasize the need for inclusion of female test subjects. This is driven by the acknowledgement that chronic pain disproportionately affects women, and it's also demonstrated by the fact that some of the previous assumptions regarding reduced biological variability in males across multiple traits are actually false. That's speaking to the idea that because men have less fluctuations in hormones, that they are easier test subjects, that they have less variability. That as a whole has been proven false in recent years. So there is much more acknowledgement of the phenomenon as a whole, which is very promising. This is my reference list, and that concludes my presentation. Thank you.